Hello. Good morning, everyone. I'm Dr. Farooq from EF Skill Lab. Today, I made this video just to make sure you change your practice from today. The issue around I'm discussing today is intubation. Well, what happens when a patient, a cardiac arrest, comes into A&E in Bangladesh? They comes in, CPR is going on, someone's doing the crash intubation. Oh, I'm saying crash intubation. This is not an elective intubation. This is not RSI. This is not an even modified RSI. This is called crash intubation. Why? Because you don't use any medication. You don't do the pre-oxygenation. You don't do anything. You just put the tube in. That's what I've seen there. Anyway, however, do we know? Well, some of times you're successful, sometimes you're not, you know. However, can you make sure, do you know if before you put the tube in, do you always check if you can ventilate the patient? Have you ever thought about ventilation? What if you couldn't put the tube in and you can't ventilate the patient? What happens? Can't intubate, can't ventilate. Do you have a front of neck access, or do you have a difficult airway trolley which has plan A, B, C, D? Have you thought about it? I don't think you did. However, yes, even before crash intubation, you need to have some plan, okay? Have a plan for difficult airway. Make sure that you ventilate the patient. By ventilation, you mean you have to have a waveform capnography, or you need to make sure that ventilation is enough. Usually, it's mandatory in UK to have a waveform capnography, so you can see the CO2 waveform, make sure you are ventilating enough with back valve mouths or Giddel airway. Well, let's assume, yes, you have the difficult plan, airway trolley or plan A, B, C, D, and you were ventilating the patient fine, okay? Then you did the crash intubation without any medication, fine. And then patient become ROSC, and while I'm thinking, now you're thinking, oh, I need to transfer the patient to CCU or ICU, yes. But what happens? Like you just transfer, bagging this patient, transfer to the CCU and ICU, and then it will take a while from them to receive the patient and then transfer the bag, and they're going to put the central line and other things. What's missing here? Main important thing is no patient after intubation should be waiting or being transferred for anything without sedation. You need to have maintained the sedation. You are putting a tube in, patient might or might not be breathing, right? You need to make sure they are sedated. They might be fighting, they might be aware, they might have a traumatic experience. So you would not, that would be a crime, not to put a patient on sedation once you intubate them. Yet you can always turn it down, or you can always put the patient off sedation and see how, if she wakes up. That's part of weaning process. But once you intubate, you don't wean the moment you intubate. You sedate the patient first, then you think about the weaning out of intubation, or you do the extubation. So this is really important for you to think. So before you do the crash intubation, make sure you can ventilate, make sure you have the difficult airway trolley or plan A, B, C, D. And after you intubate, make sure you have the sedation, ideally an infusion pump. You maintain the sedation. You may or may not need the muscle relaxant. You may need or may not need analgesia, but that comes all along. So ideally sedation, analgesia, plus or minus muscle relaxant. Patient is connected to a portable ventilator, and then they are ready to transfer to CC or ICU. However, ideally, that transfer may go through a CT scan and then to CCU and ICU, depending on the situation. Ideally, it should have a CT scan and then to CCU or ICU, but make sure the patient is stable before you move to CCU or ICU. And the patient in A&E ideally can have a central line, an ART line, monitors, portable monitors, portable ventilators, and infusion pumps, at least 3 infusion pumps or something. And then you move to the CT scan, and then you shift to ICU. Right. This, I believe this gives you an idea. However, the patient, make sure the patient can be aware of all the procedures, and you don't want to give them that trauma. This patient can be your patient, my patient, but that practice needs to be changed from today. Start thinking about it. Speak to your seniors. Let your ITU, cardiology, any consultants or seniors know. Read about it. Find it. If you have any question, just ask me or put a comment below. I will talk a bit more detail later on different types of intubation. So crash intubation, RSI, modified RSI, elective intubation, but that's a different chapter. But I just talk about the scenario around the intubation, around the crash intubation. All right. Thank you so much. I will see you soon.